To today class, so we are going to move on in neurology. So the last thing we spoke about last time, I remember that we spoke about the cerebellum and we said about different functions of the cerebellum. So we spoke about the fact that the cerebellum controls the balance, and also it does control some form of motor movement as well. However, I have a question though. In the cerebellum, we know that different portions of the cerebellum have different controls, which means something like this. Just a momento, let me open this, keep you here, and open this, and keep it here. Okay. So when we're speaking about the cerebellum, we have something called the vermis and something called the hemisphere, right? So if we are speaking about the vermis, what does the vermis control? Well, I hope you are thinking that the vermis is highly responsible for the trunk, while the hemispheres are responsible for the limbs. Okay, so the vermis for the trunk and the hemispheres for the limbs. The next thing we have to speak about today is the basal ganglia. The basal ganglia goes something like this. They are also known as like basal ganglia, and the basal ganglia, each of them is actually a nucleus. It was misnamed when they named it initially. Why? Because it's a collection of body of the neurons inside of the CNS. And how do we call a collection of the bodies of the neurons inside of the CNS normally? Nucleus, yes. So they called it ganglia. This is incorrect. However, because this term is so old, basal ganglia, they kept it. So, basal ganglia, important for voluntary, so we actually have a control over this, movement and an adjusting posture. So now comes the question, who keeps us straight, like standing up on our legs like human beings? Who give us our posture to be able to stand up, raise our head, and look forward? The answer is basal ganglia. It does receive, so let's take a look where we can find it in the brain. So the basal ganglia is the following structure. As you can see, it's inside of the brain. It's deeply inside of the brain, which means that it's kind of difficult to take it out, you know? So instead of taking out, you know, what they do in the brains, they bring this basically sausage machine and they start cutting the brain until they reach a cross-sectional area like this. And you can see all of these nuclei located here. So, for example, if you take a look at this one, which is much better picture, you can see the caudate nucleus, which means the tail-like nucleus. You can see the thalamus and the hypothalamus, okay? By the way, if you don't know what is, does anybody know what does thalamus mean? I mean, not the organ, I mean the Latin word thalamus, what does it mean? It is this thing. Okay, it's like the one for the baby crib. So that's the meaning of word thalamus. Okay, and as you can see here, we have something called the Globus Pallidus, and the Globus Pallidus internus, externus, doesn't matter for now, and we have the putamen. Okay, however, constellation of different nuclei together have different name. For example, when we say caudate plus putamen, we call that striatum. But when it is the putamen together with the Globus Pallidus, we call it the lentiform nucleus. Do you remember which disease in the GIT we spoke about had an affection of the lentiform nucleus, which is a collection between the Putamen, and the Globus Pallidus. Which disease was that? A disease that can affect the lentiform nucleus. Come on, in the GIT it was. I hope you are thinking about... Anybody? Okay, nice. Wilson. Yes. Wilson disease. It affects lentiform nucleus leading to the septums. Absolutely. Good. Also, we have subthalamic nucleus and finally substantia nigra. Which substance does substantia nigra produce? Okay, dopamine, absolutely. So let's take a look here. So they write, receive cortical input provides negative feedback to the cortex to modulate the movement. For example, yes, I have moved, stop firing. That's what it means. Basically, the basal ganglia and your cortex can speak. The next thing, however, I want you to know that only the precentral gyrus controls the movement. So the next thing goes like this. The striatum is the putamen plus the caudate. So the motor movement and the caudate for cognition, and this will be destroyed in one disease. I don't expect you to know which disease it is because we did not study it yet, but nice, okay. Somebody wrote Huntington disease, which you are absolutely correct. In Huntington disease, we have affection of the striatum, which includes the caudate and the putamen. The lentiform nucleus, however, will be affected in which disease? Yep, you are right. So Wilson disease. Okay. So D1 receptor is direct, D2 receptor indirect. What does that even mean? Well, I want you to know, first of all, when we spoke about pharmacology, we spoke about the G-coupled receptor. The D1 and the D2 are G-coupled receptor, but they are different because all of the G-coupled receptor were a kiss, except this one. They were psychopaths, so they were a psi, S and an I. So the D1 receptor is associated with a stimulatory GS secondary receptor, and the G2 receptor is associated with a GI inhibitory type of receptor. So the D1 will stimulate, the D2 will inhibit. Direct excitatory pathway. So what happens? Let's take a look down here. So yes, so something like this. Here is the thing, guys. Before I speak about it, I want you to know that it's completely useless to know this. Okay? Why? Because they don't ask about it. They ask in general about this. The first thing, which is which one is stimulatory, which one is inhibitory. The whole process is useless to know, but I have to explain it for you for completeness sake. So let's start with the direct pathway that facilitate the movement. Okay, so we want to move. Who decide that? So they write, an input from the subthalamic nucleus tell you that you should move. So let's try to move. This happens here. See? Okay. So let's start speaking about this role of movement, how it occurs step by step. Okay, so the information first of all goes to the striatum. Remember, the striatum is a constellation of nuclei. It's not one nuclei. It is one, and I will keep repeating this until you memorize this. The caudate nucleus and the putamen. Together we call them the striatum. So now it has entered the striatum. Of course, for this second, we are only speaking about the D1 receptor. And D1, was it stimulatory or inhibitory? Excellent, yes. D1 is stimulatory, so it's going to stimulate the striatum. The striatum, however, is a pretty interesting type of a nucleus. He's inhibitory in nature, okay? So he's inhibitory. However, it will go and directly inhibit the Globus Pallidus internus. Remember, I told you there was two Globus Pallidus, internus and the Globus Pallidus externus. Okay. So when it inhibits the Globus Pallidus internus, the Globus Pallidus internus will stop working, right? Normally, the Globus Pallidus internus, remember the red means inhibition, the green means stimulation. The Globus Pallidus internus normally inhibit the thalamus, okay? So if he is inhibited now, will the thalamus be stimulated or inhibited? What do you think? Yes, he will be absolutely stimulated. So again, in the direct pathway, we have direct inhibition of the Globus Pallidus internus. Globus Pallidus internus is an inhibitory type of neuron. By the way, just don't worry yourself. Both the Globus Palliduses are inhibitory. Okay, to be more fair with you guys, most of the basal ganglia, except a couple, are inhibitory. One of the couple, so one is the thalamic nucleus and the other one is the thalamus. I made a little mistake here. I told you this is subthalamic nucleus. This is wrong. This is subthalamic nucleus. This is substantia nigra baris compacta. So let me write this. Substantia nigra baris compacta. Compacta. Okay. So why it has to be that one? Because we just said this guy is the stimulatory, right? So it acts on the D1 receptor. Which hormone acts at the D1 receptor? Logically. Dopamine. Absolutely. So this is the substantia nigra coming from the dopamine. And that lead to, first of all, activation of the direct pathway that is going to what? Basically inhibit this guy. So now the thalamus do what he know to do best. Becomes crazy and stimulate the motor cortex, which is located at the precentral gyrus. After this form of stimulation, there will be a massive stimulation of the motor cortex, which is going to lead to a movement. You are like, okay, why you are speaking about it so much? Why it's important? Well, to be fair with you, you don't have to memorize the small details, but you have to know the general idea. What do I mean by general idea? I mean that you must know that the thalamus is basically a relay station that will help in the movement of many structure. Okay, see the thalamus? The thalamus is a quite interesting structure. Look what it does. When it goes here, okay, it stimulates the motor cortex, which leads to two types of stimulation. It goes to the spinal cord and it leads to the motor action. And in the same time, it stimulates this, the indirect pathway. Why it would do that? Well, it does that to inhibit the thalamus. You're like, wait. Something is messed up here. No, it's not. Let me just explain what exactly happens. Let's say that this is the palm of your hand. This is your wrist. This is your, arm bone. On your arm bone, you do have what? You do have okay, I suck at the drawing. Okay, you do have muscles, right? So here it is. You have muscles. You have flexors and you have extensors. When you flex your arm, what should happen to the extensor? When you flex your arm, the flexors contract, but the extensor, what will happen to the extensor? Relax, absolutely. So for the sake of them to relax, you must inhibit the neurons that stimulate them normally. And that's what the other pathway of the thalamus does. So it comes here, stimulates this pathway, which is going to basically, look, inhibit, and then inhibit. It's going to eventually inhibit the subthalamic nucleus. Subthalamic nucleus normally stimulate the Globus Pallidus internus. So when this Globus Pallidus internus, okay, no, I'm making a mistake now. I'm speaking about the indirect pathway. So what I just explained here is the indirect pathway, okay, guys? So what is the indirect pathway? It is the inhibitory function which can lead to inhibition of movement. So what is that? Let's stimulate this guy. If you stimulate this guy, what will happen? Globus Pallidus externus will be what? Down. Why? because this is an inhibitory. Remember, it's a D2. And what is the definition of, what is D2 coupled to? A GI. Remember, it's a psi, S and an I. So, okay, that's inhibitory. This is going to inhibit the Globus Pallidus externus. So, can the Globus Pallidus externus inhibit the subthalamic nucleus? Yes or no? Okay, let me repeat that. You are right, but let me repeat that. So, the D2 receptor is coupled to GI, which is inhibitory. Now, this is inhibitory, and now it's inhibiting the Globus Pallidus externus. So, this is gone. It's knocked out. So, can he produce the inhibitory neurotransmitter? The answer is no, it cannot. If that is true, what will happen to the subthalamic nuclei? Up or down? That's correct, it will be up. If he's up, what will happen to the Globus Pallidus internus? And if the Globus Pallidus internus is up, what will happen to the thalamus? Excellent. The thalamus will be down. And if the thalamus will be down, that's exactly what I'm speaking about. The thalamus is big. So at the flexor muscles, it was stimulated. At the extensor muscles, it was inhibited. We call this reciprocal movement. Reciprocal movement, okay? Reciprocal movement. Okay, done. Good. So, I just explained this. The moment I move to the next page, you will forget about it. I assure you that. What I want you to take from it, that the idea of reciprocal movement, to know what is the striatum, to know what is the lentiform nucleus, to know that the striatum is affected in Huntington disease and the lentiform nucleus is affected in Wilson disease. I also want you to know about something called subthalamic nucleus, which is this guy, and when he's destroyed, it leads to a disease called hemiplegismus. I just want to show you what does hemiplegismus look like, because not a lot of students know what it is. Okay, so this guy has hemiplegismus. I noticed the excessive movement of the limb. See, it's going all over the place. This is real. This is no joke. He's actually has zero control over this. This is due to a lesion in the subthalamic nucleus. This is highly debilitating for the patient and make him in a pretty bad state. Okay. So, good. Guys, you know, medicine is a little bit, can be sometimes creepy. Most of this structure, who knew how they work and how do they actually function? The answer is weird. You will not, okay, neurology, I agree, but who were the scientists who discovered this and how did they discover it? The question is. So it's actually the dark side of the science, which is like back in Nazi Germany, they used to conduct experiment in human beings, which is ethically messed up. You should never conduct such experiment in human beings. Basically, they used to destroy one structure inside of the brain and then study what is the effect on that on the human beings. Yeah, then conduct euthanasia. Total animals, I totally agree, but what can we do? So, but the science is still here. So, the next structure we speak about is going to be the amygdala, which is responsible for, what is the amygdala responsible for? Come on, you know the amygdala. Everybody knows the amygdala. Yes, so when a man tells his wife, I love you so much, my heart loves you so much, he's lying. Your heart does not love anybody. Your heart just a bomb, and it can produce some hormones, BNB and AMB. They are unrelated to your emotions. Your amygdala, however, does. So what is the medical explanation of my heart feels squeeze? when you leave me. What is the medical explanation of that? Okay, Takotsubo, you mean? Takotsubo. Okay, that's that's in case of really severe state that it's like, ooh. But in general, when somebody just loves somebody, not like it's not a broken heart syndrome. A little bit before that, we produce a lot of norepinephrine, right? And epinephrine as well. What will these catecholamines do for the coronary arteries, guys? What will they do for the coronary artery? Vasoconstriction. So here is the trick. This is why the patient feels short of breath, chest pain, and all of this stuff, because of the vasospasm of his coronary artery. It's all mediated by your brain. The hippocampus, however, is responsible for the storage of memory, in which, let's say that you saw something, it will go through your eye, blah, 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 eventually make it to your hippocampus. The hippocampus then will take it and store it inside of your cortex. The memory is so it's like, you know, when you have a computer, inside of the computer you have the memory card and you have the hard disk. So the memory card, or the RAM is functional as long the computer is on. The moment you turn it off, it gets erased and all of the info is stored in the hard disk. So we can say that the hippocampus is just a relay station. So if somebody has destruction of only the hippocampus, he will be unable to make new memories. But will he forget the old stuff? Will he forget his life? No. Okay, again. So we have this relay station. It's like a RAM and a hard disk. So what is a RAM in a computer? It's something that stores info as long as the computer is on. Or in case of a human being, it's a structure that stores the memories as long as the patient is awake. Okay? Okay, so that's the hippocampus. Then from the RAM, it goes to the hard disk. So what is this hard disk? The hard disk is a structure in which you have permanent storage of memory. So permanent storage of memory. So that will be in a human being inside of the cortex. Okay? So if I destroy the hippocampus, the hard disk is still functional. So I don't lose previous memory. But can I make memories for the future? Absolutely not. Okay. No, you cannot make memories for the future. Okay, let me repeat that. So again, we have something called the hippocampus. The hippocampus is for temporary memory, okay? So the moment you sleep, it gets erased. You have nothing in it. So where will that info go? The hippocampus will transmit that info from the from the hippocampus into the cortex, okay? From the hippocampus into the cortex. So if you don't have the hippocampus, new memories cannot go through. So this is a memory, and now it cannot go through. Old memory, however, is intact. It's untouchable. Okay. So, hippocampus is responsible for your memory. Amygdala is responsible for your emotion. Subthalamic nucleus, if it's destroyed, it will lead to hemipalismus. Caudate nucleus together with the putamen make the striatum, and these can be affected in Huntington disease, while the lentiform nucleus, which is composed from the putamen and the globus pallidum, will be affected in Wilson disease. Why? Because lentiform nucleus, right? So the next structure we are going to speak about is the brain himself, the biggest structure, the big areas. I want you to understand two things. There is centers located in the brain, and also there is general area responsible for something. What do I mean by that? Well, if you take a look at this brain, the prefrontal cortex, and the frontal lobe in general, the frontal lobe does contain the the premotor cortex, the frontal eye field, and the prefrontal cortex and the Broca area. That's correct. This is just medical, fact. But however, there is one more thing that it contains. which is the behavior of the human being. So the behavior of the human being is located at the at the frontal cortex. Let's say somebody got some form of a trauma. Does that mean that his behavior will change after the trauma? Will someone's behavior change after a trauma? Yeah. And there is a guy, I'm not sure of his name. I think his name is Venous. I'm not sure. However, he worked in the like train station stuff. And he used to make these lines for the railways, basically. And one time an explosion happened, and a piece of metal just came through his brain and did something like this. Poop. Okay? So it destroyed his frontal cortex. However, this piece of metal was so hot, that when it went through it like it entered and it exited, okay? When it went through, it was so hot because of the explosion that it burned all of the blood vessels during its pathway. Guys, this is actually interesting. If you shoot somebody here in his head, will he die? If you shoot him here. That's the messed up thing about the movies. Okay, so just movie don't work. If you want to kill somebody, you have to shoot him here, right? At his brainstem. This will kill him, but after suffering a lot. I mean, he will keep bleeding internally inside of his brain. He might look paralyzed, he might look dead, but he's not dead yet. He will bleed inside of his brain until he gets a herniation, and then he will die. That might take hours. But if you want to make sure, here. Okay? So, the next thing they write is something like this. So yeah, anyway, that guy who got this piece of metal that went in and out, after he recovered, like, I don't know, like weeks later, he came back. And people noticed something. His behavior was changed. I mean, this man used to be a really lovely husband, good with his children. The community loved him. He was good with his neighbors. He was good with everybody. Now he started to curse a lot. I mean, he speak with somebody and start cursing at him. And that was not Venous. He just changed. Why? Because of the frontal lobe affection. So can we say, in case of an anterior cerebral artery infarction, a patient behavior might change? That's possible. Yes, that is possible. Okay. Good. So let's take a look at the general areas and then we'll go more deep in them. Limbic association area is associated with the limbic system. What is the limbic system? It's the system that is responsible for our emotion, fears, and others. And this area, which is in the temporal lobe again. So again, for those who don't know, this is the temporal lobe, this is the occipital lobe, this is the parietal lobe, this is the frontal lobe, okay? How many lobes do we have in our brain? The answer is, it depends. It depends from where you look at the brain. So if I'm looking at it from the outside, you are right. It has basically like 4 lobes. If you open the lateral sulcus, you will find the 5th lobe, also known as the insula, okay? So it's highly perspective type of situation. So you can see when you just take the temporal lobe down, you can see the insular lobe. So let me send you this. Okay. The insular lobe is highly associated with the limbic system. Okay, so the occipital lobe is for vision. And here we have Wernicke and Broca. You need to understand exactly what will happen if you have destruction between them. Here we have an arcuate fasciculus. You're like, what? Well, a fasciculus is basically means like a thread. It's a connection. It's a connection between the same lobe. However, we can have like in the brain, you can have connection from up the CNS to the low to the CNS. We call this a tract, right? Up and down, vertical movement, it's a tract. When the movement is from the right lobe to the left lobe or from the left lobe to the right lobe, we call it association. If the movement is within the one lobe, anterior or posterior, inside of one lobe, we call it fasciculation. So we have atractus, fasciculation, and association. Okay. So the next thing we have, you can see the Wernicke area and you can see the Broca area, and between them there is an Arcuate Fasciculus. The patient who have aphasia of each of these will have totally different symptoms. The person with the Broca aphasia will have a frustration while speaking. He will understand you, he will hear you, he will know everything and realize everything that is occurring around him, but he cannot speak. It can happen because of a stroke. For example, let me give you an example. So let me just put here doctor and patient, and I'm going to play both of them. So I'm the doctor. Sir, how do you feel today? Doc. So you can notice the frustration of the patient. Some letters might go out, but in general, the patient is really, really frustrated, and you will be able to understand nothing because he's so frustrated speaking, nothing is coming out. That's a Broca aphasia. Okay, again, now the Wernicke area. So, again, I'm the doctor. So I'm saying, hey, so how do you feel today? And the patient is, oh, chicken, yeah, cerebral, 2 cats, 1, and yeah, ear headset, yeah, and my wallet is in the brush, and I had to go there, yeah, exactly. So, yeah, and an airplane with a car and a cup together, yes. So the patient has a word salad, we call it. Word salad, which means it makes no sense. You try to listen to the patient and it sounds like, what the hell is he speaking about? However, is the patient fluent? Is the patient fluent? Is he speaking fluently? Does he sound frustrated in any way? He does not sound frustrated. He is speaking fluently, yes. So he's like, yeah, absolutely, bed, and yeah, and tea, coffee, and an AC player, and oh yeah, well, trip, yes, 2 cats. So you can see he's fluent, but he makes no sense. For himself, will that be bothering him? Will he realize that he's just speaking nonsense in case of Wernicke area? The answer is no. He will not realize that. That's why he has the word salad. He will think that he's speaking the right thing, but what is coming out of his mouth make no sense. So who will be complaining from this issue? 99% of the time, his wife. Okay? So so his partner will come and be like, I have no idea what happened to him. Can you reset him or something? It's just like broken. So yeah, that's what happens. That's Wernicke versus Broca aphasia. What about the Arcuate Fasciculus affection? This patient can speak fluently. He can listen normally. He understands everything. But if you tell him to repeat something, he will get stuck. So, doctor, patient. Doctor, hey, so how do you feel today? I feel good, doctor. Nice, I'm glad to hear that. Can you tell me more about your day? Well, my day, it's just an association, the Arcuate Fasciculus, okay? How's your day? Well, my day was good. I woke up at 7 o'clock. I went to my work. And yeah, now I am at you. Okay, that sounds good. Now I'm going to conduct some tests on you. So I'm going to say something, and you will have to repeat the exact same thing that I say. Do you understand me? Yes, I do, doctor. Okay. So, 2 boys walked in the park. Okay. So 2 children were running inside of the museum park. So you can see he does hear you. He understands the plus or minus, but he will never be able to repeat the exact same sentence. He will twist it. So he will hear the thing, but he will not repeat it the exact same way. He will twist it in some way. For example, tell him, 2 women are in the bus. And he will be like, 2 ladies are riding the bus. He will change it. You tell him, and you are so exact about it. Don't change the words. You repeat the question, he changed them. That's a Arcuate Fasciculus problem. Okay? Otherwise, he's completely normal. Okay, good. Somatosensory association cortex, which is basically a primary sensation area of the body. Remember, please, you had 2 systems responsible for the sensation of your body, which was the spinothalamic system, or the all sensation system, which is stimulated by pain and temperature. And we had the dorsal column, which was for fine touch, vibration, and proprioception. So all of these sensations will go here, which is, as you notice here, there is like some form of a fissure, right? A sulcus. It's actually not a sulcus, it's a fissure. So now I have this common question. People always ask me, what is the difference between a sulcus and a fissure? A sulcus is something like this. A fissure is something like this, okay? So just the fissure is a little, well, not a little bit, much more deeper. Okay. So the next thing is as follows. So all of this sensation will go here, while the motor execution movement will all go here. So that's nice, that's nice. We understood a lot of things now. What about this prefrontal cortex? The prefrontal cortex does store some memory. It does. Long-term memory, however, not short-term memory. In addition, it does play a role in our behavior, not emotion. Emotion and behavior are different. I mean, if somebody is telling his wife, I love you so much, that's emotion. That's the job of the amygdala. But if the man is not putting down the toilet seat, that's his frontal cortex, not his amygdala. They are completely different from each other. So a behavior is one thing, and an emotion is totally different things. Don't mix them together. Okay, so let's have a little break for now. We'll come back and we speak about cerebral perfusion. It's a little bit complicated topic, cerebral perfusion, but really useful. I mean, you will be dealing with this, not every single day, hopefully, but you will see it in your reader practice often. So see you guys in 10 minutes. Hello everyone, welcome back. So let's continue with the cerebral perfusion. So cerebral perfusion is how much blood is making it to the brain. So let's try to understand how does that even work. Well, before I speak about anything, I'm just going to make a stupid drawing here. So this is the skull. Let me just make a skull. Okay, this is the skull. And which substance can we find inside of the skull? Actually, there are 3 things. So the first substance is blood. Excellent. Yes, CSF is the second one. So the first substance is going to be blood, right? The second substance is going to be CSF. Somebody wrote. And the third substance is going to be what? I hope you are thinking about the brain tissue himself. So brain, blood, and CSF. The idea is like this. If you increase one of these, what will happen to the other 2? They are going to get compressed. Why? Because the skull is sealed. It's a closed tissue. It's a closed organ. It does not have movement between 2 chambers. So it's a closed compartment. That's what I want to reach. So cerebral perfusion, it relies on a tight outer regulation, primarily driven by the BCO2. A BO2 also modulates perfusion in severe hypoxia. So let's try to understand what does that even mean. That means that the brain always has a constant amount of perfusion, regardless of the situation going around. Your body always tries to make sure that you have the correct perfusion to the brain. This is controlled by the level of the CO2 in your brain. Well, somebody will ask, what about the O2? Well, the O2, the brain don't care about it, except in really severe cases. So overall, in general, the brain don't care about the BOO2, which is the level of O2 in the brain. Why? Because he does not have important receptors for that. It only cares about it if it gets alarmingly low. Otherwise, it only cares about the BCO2. Oh, interesting. So why are you telling me about that? I'm telling you about that because in some cases, you can do hyperventilation. Okay, so if I hyperventilate something, what will happen? Well, you tell me, guys, what will happen to the patient if the with the BCO2 of the patient if he hyperventilate? If somebody hyperventilate, his BCO2 is going to go down big time. Okay, so if the BCO2 goes down, the brain will think that he's having a lot of blood, right? So what will happen if the brain think he has a lot of blood? He will want to decrease the amount of blood. Why? Not to get plenty of the blood that is not needed inside of the brain. So he will do what? Vasoconstriction or vasodilatation of the brain vessels. Vasoconstriction. So when the level of the BCO2 is really low, it's like you telling the brain, man, oh, I had like a lot, I have currently a lot of O2 and I have so low BCO2. So just calm down, reduce the blood flow, we are in a good state, okay? That's what you are doing. So by hyperventilating, you are leading to vasoconstriction. Why would I do that? Why would I like to do vasoconstriction of my brain? Well, if the brain was bleeding, right? Or if the brain was, for example, after the stroke, you have something called vasogenic edema that we'll discuss in a moment, but that also treatable for that. So let's see what they write here and then we'll elaborate on that. Also relays on blood pressure, a gradient between the mean arterial pressure, which is basically the blood pressure, and intracranial pressure. Nice. So what does that even mean? What it means is that if you have low blood pressure or a high intracranial pressure, you will have less perfusion pressure. Why? Again, that stupid picture I just made, it was really stupid to cancel it. Okay, let me just make it again. So blood, brain, CSF. So they write here, in cases of increased intracranial pressure inside of the brain, right? So the pressure here is increasing. So all of these guys, what will happen to them? They will be compressed. So if you compress them, what you will compress also? The blood vessels. So that will decrease the cerebral perfusion. So increase in intracranial pressure will increase the amount of blood going to the brain. There was an old, oh, here it is. There was this formula which says MAP minus ICB is equal to cerebral perfusion pressure. So if the patient has a really high blood pressure, what do you think will happen to the amount of the perfusion to his brain? He has really high blood pressure. No, it will be higher. Let's say it was 10 and this was 5. And now this is 1000. So obviously the number here will be higher if you increase the MAP. Okay, let's increase the MCB. Let's again do it like 10 and 5. So let's increase the MCB. So now it's 9. So what will happen to the perfusion to the brain? Becomes lower. So increase in intracranial pressure decreases the cerebral perfusion pressure, while an increase in the MAP will increase the perfusion to the brain. Cushion reflex, they have a triad of hypertension, bradycardia, and respiratory depression in response to increased intracranial pressure. What does that mean? Well, basically, our brain has the following activity. So they do have, when the pressure increases significantly inside of your brain, the first thing to occur is a compression of the circulatory center and the breathing center, which is going to decrease both your circulation, well, heart rate, and also going to decrease your respiratory rate. You are like, cool, nice, so what's up? Why I'm even related to that? Well, if you have, if you have less heart rate and less sympathetic activity, you eventually have less cardiac output. When you have less cardiac output, there is something called the baroreceptor. Any idea where it is located? Baroreceptor, I mean? The location of baroreceptor. No, they are not located in the heart. They are located at the aortic arch, okay? And in the carotid sinus. When they are sensing a low amount of blood coming to them, they are going to send info about this to the solitary nucleus inside of the brain. And that guy is going to lead to vasoconstriction. So let's try to understand what I just said. So first of all, before let's understand what I just said, I want you to proof check. So breathing and circulation are down because of increased intracranial pressure and compression of their centers. The next thing, the last point basically in this is this. Basically an increase in the pressure of the aortic baroreceptor, and the aortic chemoreceptor is going to basically, this is the, see the baroreceptor here and the baroreceptor here. When they are stimulated, they go to the solitary nucleus, and that will go to the sympathetic chain, which lead to blood vessel vasoconstriction. And if the blood vessel will vasoconstrict, you will have what? Hypertension. Okay. So that's Cushing reflex. The next thing is therapeutic hyperventilation. Decrease in the BCO2 will lead to vasoconstriction, and that will reduce the amount of blood flow into your brain, which decreases your intracranial pressure. So you might use it to treat acute cerebral edema secondary to a stroke. What's up with that? When somebody gets an ischemic stroke, for example, okay, let's say that this is a blood vessel, he gets an ischemia here. After that, the tissue in this area will start to die, correct? So because it starts to die, after necrosis, what comes? Acute inflammation, right? One of the symptoms of acute inflammation is the tumor, which is the edema. So to prevent the edema, what do? Hyperventilation. So when you have hyperventilation, what will happen? The perfusion to this area is even going to reduce even more. You are like, but this is bad. Yeah, that's true. It's kind of bad. But there will be no blood passing to this area. That means there is no edema. The edema is dangerous. Why? Because it can compress nearby structures. Okay? So the next thing they write about here is as follows. The CCB, the CCB, which is how much perfusion we have to our brain, is equal to the map minus the ICB. Okay, mean arterial pressure minus intracranial pressure. If the CCB is equal to 0, that means there is 0 perfusion. Shit, that means your patient is dead. Okay, that's not bad. Well, it's actually really bad. Guys, you remember the EGG? Electroencephalography? Oh, sorry, EEG, not EGG. That's an egg. So EEG, we do like to do it on a brain dead patient, okay? But to be fair with you, like on a heart, a brain dead patient will mostly be flatline. Not the whole thing, but mostly. So as you can see, boom, right? Okay. So yeah, another way of checking it is by checking how much is the blood perfusion to the brain. If it's 0, that means that there is no perfusion. There is no gradient, basically. There is no gradient, the patient is dead. Okay, so let's look at the graph and add these points onto it. You can see here the cerebral blood flow and the pressure. Let's notice what happens. Now we speak first of all about the BaCO2. The higher your BaCO2, the higher your cerebral blood flow. We agreed on that. That's why the graph look like this. The higher the amount of PCO2 in the blood, the more the cerebral blood flow. In case of hyperventilation, what I'm doing, I'm reducing the BaCO2, correct? In case of hyperventilation. So what is going to happen? Less blood flow to the brain. Okay. So the next case is, let's say the patient has mean arterial blood pressure that is ridiculously high. Remember, MAP minus ICB is equal to the CCB. So now I'm increasing significantly the MAP. So what is happening to the CBB? What is going to happen to the cerebral blood flow? It's going to increase. Absolutely. Okay, so this is the take home for these two. What about this guy sitting here? Well, in case of hypoxemia, nothing will happen until you reach this significant number, which is 50. Under 50, the oxygen starts to matter. Before 50, the oxygen matters nothing, okay? So when it is under 50, the hypoxemia will actually do increase the CCB. Only if it is less than 50. If it is more than 50, it's completely useless. CCB is directly proportional to the BCO2 until the BCO2 becomes after 90. Notice what is happening here at this point. After 90, it doesn't matter how much you increase the CO2, it will stay the same. Nothing will change. Okay, good. The next point, now it becomes a little bit easier. The homunculus. Homunculus is basically a structure, a topographical structure and a topographical representation of where is everything we sense located. Homunculus. Okay, so that's the homunculus. It's this guy. So you can notice that this person is having really big hands and really big mouth, with really big lips and really big genitalia. Why? Because these are the most sensitive areas in our body. Okay, so let's take a look at it. Homunculus, topographical representation of motor and sensory areas of the cerebral cortex. Distorted appearance is due to a certain body region being more richly innervated and thus having more cortical representation. For example, the thing we use to like deal with daily stuff, guys, they must have more area in the brain to represent them, like our face, right? However, before speaking about that, I just want you to notice this thing because that's what you get asked about. They will tell you somebody has an infarction of his ACA, which is anterior cerebral artery, MCA, which is middle cerebral artery, or BCA, which is posterior cerebral artery. I will be using the abbreviation from now on. So please, when I say ACA, MCA, and BCA, do know what I'm speaking about. I'm speaking about the blood vessel. So when I speak about an ACA, the blood vessels are going right here, and they go like this, all the way between the two hemispheres, until they go back like this. Okay, so if you want to see it, it looks like this. Okay, you can see this is only one hemisphere. You can see the ACA goes like this and then goes backward. Okay, so because of that, it does supply this area. So in the sensory area, it's the leg, and on the other side, on the motor stuff, it's also the leg. So am I telling you that people with ACA will most likely develop paralysis and disturbances of sensation in their lower limb on the contralateral side? The answer is yes. Patient with ACA infarction will develop mostly leg symptoms. Nice. What about the MCA? Well, let's take a look at the MCA. It supplies this whole thing, which is basically, to make it easier for you, it's a hand and a face. Hand and a face. Hand and a face. Right? Okay, am I saying that in case of MCA infarction, the patient will have paralysis of his hand and paralysis of his face, disturbance sensation of the hand, disturbance sensation of the face, with the sparing and no affection of the foot? The answer is yes. Okay, I hope it makes sense. So yeah, that's what's up. The next thing they speak about here is the cerebral artery, and now they start with the anterior cerebral artery. Remember, this guy starts here and then boom, supplies this whole area. This is from the other perspective of it. Yeah. So anterior cerebral artery supplies anteromedial, the medial surface of the brain. Okay. Middle cerebral artery, it supplies the lateral surface of the brain. Lateral surface of the brain. While the posterior cerebral artery supplies the posterior and inferior surface of the brain. Inferior surface of the brain, and the posterior most one, they like to ask about the posterior most one. To be fair with you guys, the question always comes about the MCA, and in real life the MCA is the most commonly to be affected. And also, if you want to make a note, the most common artery to be affected is the MCA on the left side. And somebody will be like, why on the left side? Well, because he's racist. I'm kidding. Because the left vessel normally in our human body is much more smaller than the right vessel most of the time. So he's most likely to have, us human beings are more likely to have MCA infarction on our left side than the right side. And the MCA in general is the most likely to get infarcted. The watershed area is an area between two arteries. So if we say that this is a tissue here, and we have a blood supply here and the blood supply here, right? You're like, nice, you have double blood supply, so it's even better. Not really. If you get a massive hypotension because of a bleeding or something like that, so bleeding, hemorrhage, doesn't matter, dehydration or anything like that, the first area to be affected is the watershed area, which is this area, right? Which is located between the two vessels. For example, the ACA and the MCA. Or it can be the BCA and the MCA. Okay? So let's see. Cortical border zone occurs between the anterior and middle cerebral artery, and also between the posterior and the middle cerebral artery, which is the area supplied exactly right here. So they write, internal border zone occurs between the superficial and deep vasculature territories of the middle cerebral artery. What is that? Well, the middle cerebral artery himself do have multiple vessels. So if you take a look at the MCA branches, so this is the MCA. As you can see, he has multiple branches, but here, notice here, he has this following branches going in here, and he has the superficial branches going here. So these are the deep and superficial branches, and they do also have a watershed area between them. Okay, so if that is patient in hypoperfusion, also will have infarction of the watershed area between them. So common location for a brain metastasis. Remember, the metastasis in the brain, like most likely, will be at the watershed area at something we call a gray-white matter junction. Our cortex is full with cell nuclei, not axons, but cell nuclei. So what do you think the outer cortex is made out of? Gray matter or white matter? The cortex himself. Because he's made out of, no, because the, okay, again, so the cortex is made out of the body of the neurons, the body of the neurons. So he's made out of gray matter. Under him, there is the internal capsule, right? So what do you think about the internal capsule? It's made out of white matter, plenty of axons basically going through it. So the cortex himself is a layer of gray matter. Under it, it's a layer of white matter. Okay. ACA, MCA, watershed area infarction will lead to a proximal upper and lower extremity weakness, which is a man-in-barrel syndrome. We spoke about it before. It can be also happening in some diseases affecting the bones of the brain, the brainstem. Anyway, so the man-in-barrel syndrome, it's basically they have a weakness in their shoulder, in their hands especially, but in their shoulders more often, and in their thighs. Okay, so that's a man-in-barrel syndrome. Yes, something like this. This is even a better representation in it. Yes. Okay, So they will not be able to move normally. They will not be able to raise their hand anymore. So yeah, that's Man-Barrow syndrome, BCA and MCA, watershed area infarction. They can lead to a higher order visual dysfunction. Why? Because posterior cerebral artery supplies the posterior brain, especially the occipital lobe. And what is the occipital lobe responsible for? Any idea? Vision. Absolutely correct. It's responsible for vision. So that's why it's affected. Okay, good. So let's take a look at the next thing. Just a momento. Okay. So the next thing says something like this. The circle of Willis, and what does blood supply of the brain mean? So there is two types of circulation in our brain. There is something called the posterior circulation, and there is something called the cycle of Willis, also known as anterior circulation. The posterior circulation is just, yeah, I like this picture. Okay, so this is our aorta, this is subclavian, brachiocephalic, it makes the common carotid and also the subclavian, but on the right side. Both of these get a vertebral artery coming out of them. The vertebral artery goes and bursts and go through, okay? Go through the transverse foramina of the vertebra. So it goes through transverse foramina. Just a momento. Nice. Okay. You can see how the vertebral artery goes through the transverse foramina until it enters your head. And when it enters your head, the next step comes. It joins. So inside of the head, you can see they form, they're coming together to form something called the basilar artery. And the basilar artery is going to make the posterior cerebral artery, in addition of making a communication with the anterior circulation. So that's it. The posterior circulation, vertebral artery, goes through the transverse foramina. They ask about this. And then they conjoin together, making the basilar artery, which then becomes the BCA. Keep in mind that the basilar artery have a communication to the anterior circulation. What is anterior circulation? So, except of the subclavian, we have the common carotid arteries. The common carotid arteries have external branch, internal branch. We only care about the internal branch. So the internal branch will keep going, and what will come of it is ACA and MCA. And all of these are connecting in this area. So if you look at it from a different perspective, it looks like this. So this is the posterior circulation. You can see the vertebral artery joining together and forming the basilar artery. The basilar artery is making the BCA, however, it's still making a communication with the anterior circulation using the posterior communicating artery. At the anterior circulation, we have the internal carotids joining together and making the what? They joining together and they are creating something new, which is basically going to be, so this is the internal carotid, you can see. Nice, I like this picture actually. So the internal carotid is coming like this. It helps us make the MCAs, right? And the ACAs. And between the ACAs, there is another communication. However, there is something called the Lenticulostriate Artery, which is this guy. The Lenticulostriate Artery supplies deep brain structure. Deep brain structure include the basal ganglia. Okay, so the basal ganglia are supplied by the Lenticulostriate Artery. So as you can see, the cycle of Willis is not an easy place. Just if I was you, I will ease it up by thinking anterior circulation, posterior circulation. Posterior circulation, vertebral artery, basilar artery, posterior cerebral artery. There is a communication, posterior communication, of course. Then we have the internal carotid artery, make us the anterior circulation. Middle cerebral artery, anterior cerebral artery. At the anterior cerebral artery, there is a communication. Guys, if there was an aneurysm here, it's going to push the optic chiasm, which is going to lead to vision loss. Bitemporal hemianopsia. So as you can see, the circle of Willis is not an easy place. It contains a lot of structure. The pontine artery supplies the bone, and please try to imagine that this whole structure is here. So again, this is the vertebral artery, this is the basilar artery, this is the posterior cerebral artery, and there is the communicating posterior communication, and this is the carotid, and the carotid makes the MCA and the CA, and this is the anterior communication as well. However, there is a few things to appreciate, which is something called BICA and ICA. BICA and ICA. What are these stuff? It's this guy and this guy. So it's also called posterior inferior communicating artery and anterior inferior communicating artery. Why I'm even telling you that? Don't worry about it. You will discover in the near future. Just want you for now to know that they exist. Nothing more than that. Okay, good. So let's take a look at the next thing. We are speaking now about the dural venous system. Okay, what is that? Well, we have multiple sinuses. Sinuses is a place in which the blood goes through inside of the brain. Venous blood, however, not arterial, but venous blood. So this is going to be something like this. After the brain has utilized its blood, it must drain it somewhere. After we have made the CSF, circulate the CSF, it's time to retire the CSF and send it to the dural venous sinus as well. So they are large venous channels that runs throughout the periosteal and the meningeal layer of the Dura Mater. Remember, the Dura Mater, it was the outermost area. Just for the sake of understanding what we are speaking here, it's really, really out. It's almost like under your skull immediately. So this is the structure we are speaking about right now. You can see that they are directly located under your skull. So you have also in these periosteal. Okay, nice, found it. So you can see this area. This is the sinus, but this is just a cross section of the skull. You can see the bone and you can see the venous sinus right here, right? Okay, here you go. Good. So large venous channels that run through the periosteal and the meningeal layer of the Dura Mater. It drains the blood from the cerebral vein and receives the CSF from the arachnoid granulation. What's up with that? Well, basically the idea is like this. I hope they have it next. Oh, nice. Okay, it's next. So when the CSF is made, it goes through the system and it goes down. But there's two foramina here that are called like Luschke, foramen of Luschke and Magendie. Through these foramina, you can go to the subarachnoid space. And from the subarachnoid space, you can go to the venous system using the arachnoid granulation. Okay? And finally, the venous system is going to empty into the internal jugular vein, which is going to empty into the brachiocephalic vein, which is going to empty into the superior vena cava, and back to the heart. So, let's take this overview again. The CSF is made in the lateral ventricles and the third ventricle. The CSF moves to the ductus aqueductus in the midbrain. Then it keeps going to the fourth ventricle. Then, through the foramen of Luschke and foramen of Magendie, it keeps going to the subarachnoid space. From the subarachnoid space, the arachnoid granulation are going to absorb it and send it to these guys, the venous sinuses. From the venous sinuses, it's going to gather up to make the internal jugular vein, to drain into the internal jugular vein, and then it's going to go back to the heart. Okay? Okay. So now they are speaking about a case in which we have venous sinus thrombosis. Venous sinus thrombosis, the first thing I want you to know that it happens because of hypercoagulable state. What can lead to hypercoagulable state? So many things, including pregnancy, because they have a lot of estrogen, OCBs, because they have a lot of estrogens, and factor 5 laden, which is an insensitive factor 5 to the anticoagulant protein C, so that they become hypercoagulable. They write, it presents with signs and symptoms of increased ICB, like headache, seizures, Bevel Edema, and focal neurological deficit. I feel it is unfair for you to speak about Bevel Edema without seeing one. Bevel Edema. The Bevel Edema is a thing that you can see on fundoscopy. You cannot see it with your own eye. You have to put a mydriatic inside of the eye, And after that, look with a fundoscope and you will be able to see this. What is this? Look, can you see the disc here? You cannot. You cannot visualize the disc of the eye normally. If you look at the edges, it's like there's something messed up here. You cannot see the edges. Because you cannot see the edges, that's it. That is Bevel Edema. So let's just me giving you the comparison. So here, this is an optic disc. Can you see the edges? The answer is yes. So this is not a Bevel Edema. So Bevel Edema, you cannot see the edges of the disc. Okay. So they have Bevel Edema and focal neurological deficit. Focal neurological deficit means that the patient have neurological symptoms that correspond to one area of the brain. Okay? So it may lead to venous hemorrhage, and it's associated with the following. You can see hypercoagulable state, like a pregnancy, OCBUs, or factor V laden. All of these are causes of venous sinus thrombosis. The next thing to speak about is the ventricular system. Awesome. We spoke about it already twice. So, without further ado, we have the lateral ventricle. Goes to the third ventricle through the foramen of Monroe, also known as the right and the left intraventricular foramina, which is this guy. You can see this is foramina of Monroe. And basically the lateral ventricle are located within the hemisphere, within the telencephalon. However, the third ventricle is located inside. Can somebody tell me inside of which structure do we have the diencephalon located? Remember, yes, excellent. The encephalon is where it is located, which is composed of the thalamus and the hypothalamus, right? And for the next structure, which is the third ventricle, goes to the fourth ventricle via the cerebral aqueduct. So where is the cerebral aqueduct located? Within which brain is the cerebral aqueduct located? So the cerebral aqueduct, it's located in the midbrain. Okay? Midbrain. The next thing is the fourth ventricle. I will not ask you about this because it's a little bit confusing. So posteriorly of the fourth ventricle is going to be the cerebellum. Anteriorly, it's going to be the bones. It's going to be the bones and the medulla. Okay? Okay. So they write here, third to fourth through the aqueduct of Salvius, fourth to the subarachnoid space through the foramen of Luschka, which is located laterally, and the Magendie, which is located medially. And the CSF is made by the choroid plexus, which is located at the lateral and the fourth ventricle. And they travel in the subarachnoid space via the foramina of Luschka and Magendie, as we said, and they are reabsorbed by arachnoid granulation, and then it drains to the dural venous sinus, which goes back to the jugular vein and back to the heart. Now that comes to the question, why you are telling me so many structures? Telling you so many structures because, for example, they can tell you that the patient has only dilatation of his lateral and third ventricle, and you have to assume that the obstruction is located at the cerebral aqueduct. Sometimes the question comes at, like somebody had meningitis and after that he has hydrocephalus. What's up with him? The answer will be the arachnoid granulation were inflamed and destroyed, which has prevented the reabsorption of the CSF, and thus they have developed hydrocephalus. The next picture is about the veins. Oh, so this is the brainstem and all of the veins coming out of it. So let me make it simple for you. Now they make this nice. I like it. So yeah, factors of 12 except 1 and 2. So basically what I tell myself, the last, you can use this if it works for you. This is perfect, but personally I have my own way. So I tell myself, I saw it in Boards and Beyond actually. I'm not taking the credit for it. But 12, 11, 10, and 9, which is the last 4, all of these comes from the medulla. Now the 4 after them. So 8, 7, 6, and 5. I was like, he was like, okay, these are the bones. And then he was like, okay, so now we have 4 and 3, they come from the midbrain. What about 1 and 2? Don't think about them, they come directly from the brain. 1 is olfactory bulb, you can see it here, so it's an olfaction, it goes directly to the brain, it does not even have to go through the thalamus. Olfactory tract is here, so olfactory bulb First of all, we have fila olfactoria, which coming from the nose. We have olfactory bulb, then olfactory tract, then olfactory trigonum, and then it goes to the brain, to the uncus to be more exact. So the last center for the olfaction is the uncus. So cranial nerve number 2 is the optic chiasm, and you can see it going up here. And the next things are going to be as follows. They write here, they go to this area. So we know that the 12, 9, and 10 and 9 come out from there. But what we do not know is which one goes medially and which one goes laterally. I will give you the trick. Okay, does a 12 divide on 12? Yes or no? Can you divide 12? Yes, you can. So it goes medially. If it divides, it's medial. If it does not, it's lateral. Can 11 divide on a 12? Or can I divide a 12 by 11? You cannot, so it's lateral. 10. Can you divide 12 by 10? How? No, you cannot. You cannot divide the 12 by 10. I'm saying a way of division that it will be not like 0.1. No. Should be full number. So 12 on 10, it will be like 1.2 maybe. So it's not correct. I just wanted to have an exact number. So 10 cannot. So it's lateral. Can you divide it 12 by 9? 12 by 9. Can you do that? No, you cannot. So it's lateral. What about 8? No, so it's lateral. What about 7? No, then lateral. What about 6? Yes, 12 on 6 is 2. So this is medial. What about 5? No, then it's lateral. What about 4? Yes, it's medial. What about 3? Yes, then it's medial. Okay, so we can determine all of them just by checking if it divides on 4 or not. Let's proof check that. Cranial nerve number 12 is the most medial between all of the other guys. So you can see 12, he's medial, he's here. 11, 10, 9, all of these are lateral, as you can see here. Okay, all of them are lateral. So this is like 11, 10, 9, all of them are lateral. Nice. So that was proof checked, proof checked, proof checked, proof checked. So now between these, only 6 should be medial, only 6. So if they show you a picture of this, you know nothing. But they show you a picture of this, this is medial, the most medial one. Which cranial nerve is this? You tell yourself, okay, so it's the bones. The bones only have, it's the bones, guys. The bones, which cranial nerve come out from the bones? So it was not the last 4. The last 4 were from the medulla, which was a 12, 11, and then 10 and 9. So the bones should come out of it. It will be, should be like 8, 7, 6, and 5. 8, 7, 6, and 5. And from these 8, 7, 6, and 5, the only one that divides by 12 is cranial nerve number, which one is it? Cranial nerve number 6, yes. So this should be cranial nerve number 6. That is the trick, guys. So it's a two-step type of thing. First of all, check where are you? Get oriented. We are in the medulla. We are in the, here in the bones. But if you are in the medulla, you have to think differently. So to make the matter more easy, see, just hide one area of the brain and leave one area left, okay? So if this is 6, look how easy it is. 7, 8. So you just keep counting the number. 9. So if you take a look here, cranial nerve number 6, 7, 8, 9. Got it? So the lateral you go, the more the number in case of the bones. Okay, good. So all of these were proof checked. Now we have the last 2, which are cranial nerve number 3 and number 4. They come both from the midbrain. it's difficult to visualize in this area, so I want to look from another area. You can see that they put here cranial nerve number 3 and the cranial nerve number 4 here, but you cannot visualize it good. So I would like to show it to you on a better image. Okay, so okay. Okay, so what's up with this guy? I want you to see that the midbrain, it's true, it has two cranial nerves. The oculomotor one, which is originating from anteriorly, and the trochlea, it looks lateral. You lied at us, you bastard. No, I did not. It also originates medially, but from the posterior side. So it goes medially from the posterior side, and then goes around, okay? It goes around, but initially it comes, what? Medially, guys. It came medially from your brain. So why I'm keep speaking about this? The cranial nerve number 4, which comes like medially but comes from the posterior side and go to the anterior side, his name is the trochlear nerve. Okay, they call him the trochlear nerve, and the trochlear nerve can be affected by it helps to supply one muscle of the eye, but it can be affected by some disease. Okay, and this specific disease is causing a problem in this guy only because of its location. So it's originating posterior, as you can see. This is the trochlear nerve, posterior from the midbrain. Because of that exposes him to the pineal gland. The pineal gland is immediately located behind him. Okay, I hope this is a good image. So because of the pineal gland being located immediately after, behind him, in case of a pinealioma, which is enlargement of the pineal gland, the first nerve to be compressed is the trochlear nerve, which is going to lead to symptoms regarding it. So pineal gland and trochlear nerve. Okay. Okay, you can see the pineal gland and the midbrain is under it. This is the oculomotor, it's anterior, and this guy unnamed, this guy, this is the trochlear. So if this gets so big, it's going to compress this guy. Okay, that's quite common in this type of neuroscience. Oh my god, this neuroscience, so difficult. Nah, not that much. Okay, so the next thing, let's see. Okay, good, the cranial nerve, toasted. The next one, the brainstem. You can see here the pineal gland, which is responsible for circadian rhythm, secretion of melatonin, and it's the only thing that makes you wake up or sleep. So pineal gland, melatonin secretion, and circadian rhythm. You know, people sometimes they say they are jet lag when they travel from country A to country B. That's because their circadian rhythm is messed up. So you can put that on your pineal gland. Next, the midbrain also contains a couple of structure here. They contain something called the superior colliculi and the inferior colliculi. The superior, remember, your eyes are superior to your ears. So direct eye movement to stimuli like noise or movement or object of interest. What do I mean? Guys, you know, you are out during the night and a cat run so fast in front of you and say, "Ow!" That's not a cat. Anyway, your eyes will be drawn to it and you will be looking at this object moving really, really fast. Are you thinking while you are moving your eyes, or they just move spontaneously with you? Exactly. Or you are walking on your own street, like on the street, peacefully, and some asshole have this types of car that makes like this really loud sound. Suddenly it's like an explosion sound. What your neck will do, you will flip your neck suddenly and look at the stimulus where the sound came from. Yeah, that's your superior colliculi did that, okay? And that guy should get a ticket. So superior colliculi, direct eye movement to stimuli, noise/movement or object of interest. The inferior colliculi, however, are responsible for the auditory, On the exam, they will tell you about somebody who got an injury of one of these structure, and they will tell you what's up, what is going to happen to him. Inferior colliculi, he will become deaf. Superior colliculi, he will have a visual problem. This is why I told you the story about the Nazis in the beginning of the session. For the sake of you to understand how people studied neuroscience in the first place, to understand what type of a question you can get on that. So your eyes are above your ears, and thus the superior colliculi will be visual, while the inferior one will be auditory. Okay, so now let's take a 10 minutes break, and after the break we'll keep going. So see you guys in 10 minutes. Okay, cranial nerve nuclei. The cranial nerve nuclei, the definition is, it's a collection of the head of the neurons. So guys, if you have something like this, look, this is not head but body, sorry what I'm saying, body of neurons. All of these guys can collect together to form this. What is this? No, this is a nucleus. This is a nucleus. This is this one here is a nucleus. But this here, the collection of the axons, this is a tract, right? This is a tract. This is a nucleus. Now I have a question, guys. What is more dangerous? If you have injury of tract, which is white matter, or a nucleus, which is a gray matter? Everybody gets tricked with that. Guys, look, if you have a knife and you damage these, you destroy 2 out of 1, 2, 3, 4, 5, 6, 7, correct? You destroyed 2 out of 7. But if you have a knife and you cut this, how many have you destroyed? 7 out of 7. So which one is more dangerous? White matter injury or a gray matter injury? Absolutely, the white matter injury, which is the tracts. Okay, everybody get this mistake. This is why we love to take the biopsy from the gray matter, not from the white matter of the brain. However, sometimes we are forced to take it from the white matter. You are like, wait a second, are you speaking about a brain biopsy? Yes, there is such a procedure. The brain is a really complicated structure. There is a lot of things we can speak about in it. There is a lot of diagnoses you can get from a brain biopsy. The worst one is racemeucine, which is a type of encephalitis that can basically kill the patient really quick. Okay, happens really in really small children, affect one hemisphere, called racemeucine, the name of the encephalitis, and they die within a few years if you don't manage it. The management is more horrible than the disease. You have to cut half of the brain of the baby, okay? The earlier you do it, the better the prognosis. I mean, if the child was 2 and you diagnosed it and you removed half of his brain, will he be able to walk, speak, see in the future? The answer is yes. The answer is yes. Anything less than 4 years old. When he becomes more than 4-year-old, that's a little bit too late. Okay? So if you diagnose something like that, tell the parents, listen, this is your only chance. Either you do it or you don't. It's horrifying. You have to cut half of the baby head, baby brain. Initially, he will be paralyzed, unable to see in one eye, all of these symptoms. But within few months, there is something known as neuroplasticity, in which the other portion of the brain starts functioning normally, and even some brain tissue will be growing. You're like, wait a second, brain tissue does not grow. Yes, it does not grow in us, adults. But this is a baby, a really small child. It still grows. So the nuclei are located in the tegmentum portion of the brain stem, which is located between the dorsal and the ventral portion. So if you have a brain stem like this, you have always these 3 areas: anterior area, tegmental area, and posterior area. So the midbrain have the cranial nerve of 3 and 4, bones 5, 6, 7, 8, medulla 9, 10, and 12. While the spinal cord have the nucleus of a cranial nerve number 11. But the trick about number 11 is like this, which is, yes, which is basically this is a cranial nerve number 11, as you can see. The nucleus is located in the spinal cord, I agree, but it re-enters into your foramen magnum, right? It attaches to the midbrain, and it re-exits from your brain, okay? So that's why we say that cranial nerve number 11 is actually coming from the medulla. His nucleus is coming from the spinal cord, but the nerve himself is coming from the medulla. Okay, lateral nuclei are most likely to be sensory, while the medial one are most likely to be motor. Okay, that's true. So let's take a look at the vagal nuclei. We have 3 of them. We have a nucleus tractus solitorius, ambiguous, and dorsal motor nucleus. Starting with the first one, we have the solitorius. It has some sensory information, but visceral sensory information, which can tell you about the taste. They can tell you if your tummy is full, if you need to poop, and if you have like high blood pressure. So these are going, just if you were me, try to make it easier on yourself, and remember which cranial nerve are responsible for the taste inside of the mouth. And I told you about the 3 of them, if you remember. Do you remember? It was cranial nerve number 7 for the anterior portion, right? And 9 for the posterior 2/3, and 10 for the epiglottis. So, nucleus ambiguous is solely motor. So motor innervation of the pharynx, larynx, and upper esophagus. So it helps you to swallow, and the palate elevation, which also help you to swallow and pass the food posteriorly. So it's going to be cranial nerve number 9, glossopharyngeus, vagus, and accessory nerve. Accessory nerve has really important function, which is mentioned here, of how it controls the motor movement of your trapezius muscle and the sternocleidomastoideus. The dorsal motor nucleus, it sends an autonomic parasympathetic fibers to the heart, lung, and the upper GI. These parasympathetic fibers help the peristalsis of your GI. Also, it have a function in your lung, the parasympathetic pathway, to basically lead to bronchoconstriction. And the fibers going to the heart can lead to bradycardia. Okay, the next thing we are going to speak about is how the hell they pass through our brain. I mean the nerves. So, there is a special foramen, a special hole inside of your cranium. This is the base of the cranium, of course. That the nerve passes through. So for the areas of the brain are subdivided, of the cranium are subdivided as follow: anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. In the anterior cranial fossa, there is something here known as the ethmoid bone. The ethmoid bone is actually a long bone, but it goes downward. It has something here known as the cribriform plate, and this is known as the galla. Anyway, the cribriform plate is like a, let me just draw it here. So the galla is in the middle, of course, but this is just the thousands of holes located here, which is through them there is something known as fella olfactoria. Fella olfactoria passes through them, which attaches itself to cranial nerve number 1, which have this like olfactory bulb. Guys, I know it's messed up, but people who sniff cocaine, that's what they are stimulating, this guy. Can we stimulate it with other things? The answer is yes. Addicts discover that direct stimulation of the olfactory nerve make them feel high. So they started discovering other things. For example, cocaine is really expensive. I'm teaching you this, guys, because like some people do it and you are doctors, they come to you and you are like, what the hell he has done to himself? So they get the cocaine, and in addition to cocaine, I hope the police is not looking at my laptop now. So they get the glass. So, and the glass, like an actual glass, and they bring the glass and they keep crushing it until it becomes a powder. Okay? So they get the glass powder and they mix it up with the cocaine and they sniff it. This little glass particle are going to lead to local injury inside of your bulla olfactoria. And the cocaine can enter into your bulla olfactoria in much more easier way. Okay? The middle cranial fossa goes something like this. We have the optic canal and we have the cranial nerve number 2, which is the optic nerve. It goes through the optic canal. Remember, it's a sensory, so it goes in, not out. So it's coming in and then it forms the chiasma optica, which continues inward. In addition, through the optic canal, we have the ophthalmic artery coming through it, which is a branch of the internal carotid artery. The next thing is the superior orbital fissure, or fissura orbitalis superior. We have the cranial nerve number 3, 4, and 6. These 3 cranial nerves, all of them are responsible for the motor movement of the eye. Okay, make a note about that, motor movement of the eye. In addition, the ophthalmic branch of cranial nerve number 5 goes through it. Ophthalmic branch of cranial nerve number 5 is also known as the V1, so it also goes through it. Okay, that was superior orbital fissure. The next one is foramen rotundum. So foramen rotundum, this guy, it's rotundum. It means like round, perfectly round. Okay, rotundum means perfectly round. So cranial nerve number 5, V2, which is the maxillary portion. Okay, the maxillary division. And finally, ovale. Rotundum is perfectly round. Ovale is something not perfectly round. Okay, so the ovale is this guy, and the cranial nerve number V3 go through it, also known as the mandibular division. Foramen spinosum, the middle meningeal artery comes out, goes through it, but this is a pretty interesting type of artery. Why? Because the maxillary artery has this branch. Okay, so if you speak about the maxillary artery, we have a branch of it that goes right here. So from it, it goes something like this. So you can see this is the maxillary artery, and from the maxillary artery, we have a few branches. I cannot, okay, just a moment. Yes, okay, you can see it right here. Can you see the middle meningeal artery? It's piercing the skull from the maxillary, piercing the skull through the foramen spinosum, and eventually entering your brain cavity to supply your brain. You are like, yeah, that's cool, but what is the clinical significance? The clinical significance, if you have a massive inflammatory reaction within this portion of the face, it's highly likely to this infection to drain into your brain. Okay? Okay, so the next thing we have is the posterior cranial fossa through the temporal or the occipital bone. Let's speak about that. So we have the internal auditory meatus. Internal auditory meatus, well, auditory, yes, auditory, so it's something related to hearing, probably. Yeah, but not solely. So through that, we have a cranial nerve number 7, which is the basically the facial nerve and the vestibulocochlear nerve. Vestibulocochlear nerve is for balance and hearing, but the facial nerve is more like kind of motor. I want to speak a little bit more about the facial nerve. The facial nerve is much more complicated than you think. So the facial nerve route is actually quite interesting. So it's true that it enters the anterior acoustic meatus, but it's not the end of the story. I mean, after that there will be few more things. What do I mean by that? Let's take a look. So now it has entered through the internal acoustic meatus, which is right here, right? I'm speaking about the green nerve. The green nerve is the facial nerve. So after it goes through this, it's going to keep going and go to the superior lateral wall of the middle ear. This is the middle ear. This is the superior lateral wall of the middle ear. It will burst through it and then goes to the posterior wall of the middle ear, and then it will go down into the Steelomastoid Foramen. Okay? The Steelomastoid Foramen is going to give divisions. So let me just send this and then just try, hopefully. They will show it in a better way. Otherwise, I have to draw it. Okay, so let's see what they give us here. Okay, good enough. Okay, you can see how it's going through the internal acoustic meatus. It goes superior laterally to the middle ear. This is the middle ear. And then posterior to the middle ear. And then through the Steelomastoid Foramen, it goes outside of your skull. Okay? You're like, wow, cool story. Why are you telling me about it? Well, if somebody has a middle ear infection that is pretty massive, does that mean that it can lead to a facial nerve palsy? What do you think? Yes. In a massive type of inflammation of the middle ear, it can lead to facial nerve palsy, and it can have symptoms of the facial nerve. The facial nerve, however, does also supply a few branches, as you can see. See this branch, for example, the stapedius muscle branch, which is going to contract in case of really loud noises. For example, an explosion happened next to the patient. This is going to contract, which will prevent the patient from destroying his inner ear. Okay? It dampens down the sound, basically. Okay, this is the middle ear topography, which has like all of the 6 walls of the middle ear. You can see you have the basically the medial wall, lateral wall, posterior wall, superior wall, the inferior wall, and within each wall there is something. This actually really good picture because it tells you, for example, yes, that's why people who have, for example, one moment, let me just add this. Okay, this is why people, for example, who have a middle ear infection, it can go and lead to temporal lobe meningitis. Why? Because this is the brain, right? And the portion of the brain that is located immediately right here, it's the temporal lobe, okay? And the temporal lobe, if it's inflamed, that's it. The patient will get the problem, right? Which is, could be abscess of the brain formation from a middle ear infection. So, the next one is the Gigolo Foramen, in which we have 9, 10, and 11, and the jugular vein going through. Hypoglossal canal, well, I should not speak about this. It's cranial nerve number 12, which is hypoglossal nerve. Foramen magnum, really massive foramen. Cranial nerve number 11 goes through, which is accessory. You're like, wait a second, but you just said about number 11 to be through the jugula. Yes. So number 11 is actually a bit tricky. So what he does is that he enters the skull from the spinal cord to the through the foramen magnum, and then it exits through the jugular vein out of your skull. So it enters and exits your skull. That's cranial nerve number 11. Vertebral artery, remember, they conjoin together to make the basilar artery, which eventually is going to form the BCA, posterior cerebral artery. And the posterior cerebral artery are going to give the posterior communicating artery to communicate with the cycle of Willis. The cycle of Willis is formed from the internal carotid artery, which is going to eventually make us the BCA and the ACA. The ACA is going to communicate together through the anterior communicating artery. Anterior communicating artery aneurysm can compress the chiasma optica, which can lead to bitemporal hemianopsia, a type of a blindness. Okay, so now we have the midbrain. It can have its medial, the nerve coming out of it, which is the 3 and 4. Laterally, we have from the bones number 5, 7, and 8, while medially only number 6, because it divides on it. In the medulla, medially we only have 12, and the rest comes laterally. Just use the rule of 12 I just gave you. Okay? The other structures are going to be something like this. So we have the vertebral, and they conjoin to make the basilar, and the basilar make the BCA. And here you can see at the anterior circulation, we have the internal carotid, which gives the ACA and the MCA. Okay, good enough. So in the next class, we'll finish up the physiology. The pathology of the CNS is much more easier than the physiology of the CNS. So practically, when we finish this portion, which is the physiology of the CNS, which we'll be doing on tomorrow, we will be pretty much done with the difficult portion of the CNS. The rest is just pathologies. If you understand the physiology, the pathology becomes a piece of cake. So that's it for today's session, and I will see you